Can I start?
Yes, we can start, sir. We first give your introduction and then we will start. Yeah.
Yes.
Yes, sir. Yeah. Sankalp?
Yes.
Huh.
Yes, good evening all and good evening doctors. Myself Sankalp Sani, Marketing Manager at InnovCare Life Sciences. Welcome all to this interactive show, the Pundit @ Dr. Ritu show, supported by InnovCare Life Sciences. Today we have very special guest on our show, the teacher of the teachers, Dr. Aboubakr. Welcome, doctor.
Welcome.
Yeah. It is important for us to understand what makes Pundit show unique and special. It is a knowledge sharing platform for experts as well as young doctors. The perfect mixing and mingling done by Dr. Ritu when it comes to strike balance between basic questions and advanced questions. Not only from India, but doctors from across the globe are getting benefited from this show. It has covered all the aspects, be it gynecology, obstetrics, sexual wellness, women's health, medical legal aspect, and others. With this, I would like to request Dr. Ritu Madam to introduce our special guest, the teacher of the teachers, Dr. Aboubakr. Elnashar. Over to you,
Thank you very much.
Yeah. Thank you, Sankalp. Sir, we will do your official introduction first, then we can go for the talk. So welcome to all our
thank you.
Yeah, welcome all the friends and all the doctors who have joined from the India and all across the globe. So namaskar to all of you and salam to all the friends who have joined from Egypt and the Arab countries. So our today's guest is very, very special, a very well-known personality. Sir is accepted my invitation on a single phone call. Sir, a very warm welcome to you. I am here, your host, Dr. Ritu Santwani, Director, Shyam Well Women Clinic and Pune TestTube Baby Center. So, Vaibhav, can we have the biography of Sir, please?
Sorry?
So, just a second. We are doing your introduction.
Yes.
Yeah. Our today's guest is very special, Dr. Aboubakr Elnashar. Sir is co-author of the books of the Gynae for the medical students, Obstetric for medical students, ABC of reproductive endocrinology, recent advances in endometriosis, advances in medicine. Sir is the professor of Obs Gynae, Behana University Hospital, Egypt, president of the Clinical Society of OBGYN, editor of Middle East Fertility Society Journal, Egyptian Fertility Society Journal. Sir has 37 international publications in the Lancet, Human Reproduction, British Obstetric Journal, Fertility City Journal. Sir is a speaker in so many international conferences, ISHRE, RCOG, European Congress of Obstetrics. Sir is having 455 lectures on SlideShare. Amazing, huh? Actually, I am very, very much impressed after reading Sir lecture in the SlideShare. So I thought I should approach the Sir. And sir, really, I'm very, very thankful to you that you accepted our invitation. So sir is going.
Thank you.
Yeah. Sir is going to discuss with us today a very, very important topic, the ovulation induction for the IU and IVF. So already we are delayed. So without wasting much time, I'm handing the show to the sir. Sir, over to you. Thank you so much.
Thank you very much. I am happy. And thanks for this kind invitation. I visited India twice, and I would like to visit it more and more. And thanks, Dr. Ritu. And we'll start the first. Yes, are you listening to me?
Yes, sir. Sir, we are listening.
Very good. As you mentioned, I have more than 455 lectures on the Facebook and also on my scientific page and on a SlideShare for free download. And we will discuss today ovulation stimulation protocols in IUI and also in IVF.
Yes.
Let's start by the types of ovarian stimulation. We have 3 types of ovarian stimulation according to our objective and according to the type of the patient.
Yeah.
We have induction of ovulation if the patient is anovulatory, and the sober ovulation if the patient is anovulatory or ovulatory. And our objective is to get more than 1 follicle. And we have the controlled ovarian stimulation, which is done in IVF. So it is very important to first to determine what is our objective. What is the rationale of ovarian stimulation in IUI? We want to increase the number of the oocyte.
Yeah.
We want to increase the steroid production, which may improve the chance of fertilization and embryo implantation. And also, by doing the ovarian stimulation, we are controlling the time of ovulation and the insemination. And all of these will increase the pregnancy rate. It was found that stimulated IUI is more likely to result in a live birth than the IUI in natural cycle. What is the disadvantages of ovarian stimulation? The cost of the drugs, the monitoring, and also it has its cost, and also the complications of sober ovulation. Two important complications: multiple pregnancy, which accounts for 7 to 13%, and ovarian hyperstimulation syndrome. The ovarian hyperstimulation syndrome is very rare in stimulated IUI because, as we mentioned, our objective is to get only 2 to 3 dominant follicle. It is only observed with gonadotropin cycles, and it is very rare in clomiphene citrate cycle. This raises the importance of the regular ultrasound monitoring to detect the hyper response early and to manage this early. The third item to be discussed, we should prevent these complications. We should prevent or avoid the multiple pregnancy and ovarian hyperstimulation syndrome. So, as we mentioned, the IUI should be stopped if we have more than 3 dominant follicles with a diameter more 15 millimeter, or if we have more than 5 follicles with a diameter 10 millimeter. In this condition, we will not trigger. When the second method to prevent the complication is when gonadotropin is used, we should start with a lower dose, that's to say 75 international unit, because higher doses are associated with similar pregnancy rate, but increase in the multiple pregnancy rate and ovarian hyperstimulation syndrome. The third method to avoid the complications is to use the clomiphene citrate or tamoxifen as an alternative to the low dose gonadotropin. But in this condition, we should keep in mind that the live birth rate will be lower and also the cost will be lesser. The addition of the agonist is not recommended because no increase in the pregnancy rate despite the increase in the multiple pregnancy and also increase its cost. The last method, and may we do it or not, is aspiration of the existing follicles to avoid cycle cancellation. The item to be discussed after that, what is the optimum ovarian stimulation for IUI? We should maximize the probability of conception, and we should minimize the complication. That's to say, 2 to 3 follicles with a diameter 18 to 19 millimeter, and the endometrial thickness 9 millimeter thickness, and the IUI to be done in the day 13 to day 16. But let us see what is the recent systematic review regarding the importance of the endometrial thickness in IUI. It was found that there is no evidence of a difference in the endometrial thickness between women who conceived and women that did not conceive. That's to say, the endometrial thickness monitoring of no value in stimulation for IUI. And there is no evidence in the endometrial thickness when comparing clomiphene citrate and letrozole. Our concept or our knowledge that the clomiphene citrate is associated with a decrease in the endometrial thickness relative to letrozole, but according to this recent systematic review, there is no difference in the endometrial thickness. When Are we going to stimulate the cycle in all indications of IUI? Let us see. For unexplained infertility, yes, we should stimulate the IUI, because with stimulation, there is a significant increase in the cumulative live birth rate compared to the expectant management and compared to the IUI in natural cycle. What is about the if the indication of IUI is minimal or mild endometriosis? Again, the ovarian stimulation is highly recommended in this condition. What is about if the indication is mild male factor infertility? If there is a mild male factor infertility and the number of the count of the sperm is less than 10 million, there is no improvement in pregnancy outcome if stimulation is used. But if it is more than 10 million, there is an increase, or there is a value of ovarian stimulation in IUI. Monitoring of the ovarian stimulation is very important, and the methods for monitoring are the ultrasonography, doing serial folliculometry, and endometrial thickness. And also we can monitor this cycle by using the urinary LH search, which is easy and is available. And it is done when the dominant follicle reaches 18 millimeter with endometrial thickness more than 7 millimeter. And IUI ideally to be done on the same day, preferably by the evening if the LH gets become positive in the morning. What are the protocols of ovarian stimulation in IUI? We have the oral, the clomiphene citrate with or without adjuvant. We have the combination of clomiphene citrate and gonadotropin, the aromatase inhibitors, the letrozole, gonadotropin, agonist protocol, or antagonist protocol. Why we have different drugs and protocols? Because our patients are not equal, and the response is quite different from one patient to another. And the response is dependent on the most important, the age of the patient, the ovarian reserve test, the pelvic pathology, and the body mass index. Let us start by the clomiphene citrate, which is cheap and available, and it is good for sober ovulation and for induction of ovulation if we have a patient with enormous thyroid function, normal serum prolactin, and a normal endogenous estrogen level. But please keep in mind, it is not indicated, it is not effective in women with hypogonadotropic hypogonadism. In this condition, we should give gonadotropin with LH activity. Recombinant FSH is not effective in this condition. The second protocol is the combination of clomiphene citrate and gonadotropin. And we have three methods to combine clomiphene citrate with gonadotropin. The first is the scattered one, that's to say, to give the gonadotropin in day 3, day 5, day 7, and day 9 with clomiphene citrate. The second is sequential one, that's to say, after the completion of the clomiphene citrate, to give it in day 5 or in day 7. The third method of combination between clomiphene citrate and gonadotropin is the fixed one, to give gonadotropin on day 3 and day 8. And many one ask, why on day 3? On day 3 to recruit 1 or 2 additional co-dominant follicle, and on day 8 to counteract the anti-estrogenic effect of clomiphene citrate and to enhance the pre-ovulatory estradiol level for effective LH search. The third is aromatase inhibitor, and this study published in the Lancet, and as we see here, the clomiphene citrate and the letrozole both are equal and effective, and this was compared with expectant management for 3 cycles. The cumulative live birth rate for clomiphene citrate or letrozole was 31, while in expectant management was 9% only. That's to say, oral ovarian stimulation IUI is an effective treatment in unexplained infertility. The fourth is the gonadotropin, and the best is the daily basis, the low dose protocol, and as you mentioned, 75 international units is enough. And according to H3, with gonadotropin stimulated IUI, the pregnancy rate per cycle is 12%, and the multiple birth rates 13%. This study comparing between the three methods of ovarian stimulation, letrozole, clomiphene citrate, and gonadotropin for 4 cycles. And as we see here, the cumulative live birth rate with letrozole 18%, with clomiphene citrate 23%, and with gonadotropin was 32%. And there was no significant difference between the three methods. And
Sir, sorry to interrupt you. Sir, we are not able to see the slides.
You cannot able to, how?
No. Sir, you have to share the screen.
What I will do?
Sir, share
all
the
slides
screen. So down there is a button, there is share screen.
Yes, just a minute.
Yeah.
It's okay now?
Yes, it's okay now. Yes, sir. Yes, sir, perfect.
We want to compare between the different protocols. And this is the golden source of our knowledge is the Cochrane Systematic Review. The Cochrane Systematic Review, 43 trials involving more than about 4,000 women. Comparing gonadotropin with anti-estrogen, there is a significant higher pregnancy rate with gonadotropin. Comparing anti-estrogen with aromatase inhibitors, no significant difference. Clomiphene citrate equals letrozole, but clomiphene citrate is much cheaper than letrozole. Only the letrozole is better than clomiphene citrate in polycystic ovary syndrome. Adding agonist didn't improve the pregnancy rate, although it resulted in significant higher multiple pregnancy rate, and that's why the agonist protocol is not recommended. And the same for the antagonist protocol. No convincing evidence to give the antagonist protocol. Comparing the different types of gonadotropin, there is no difference between the recombinant or the urinary or the highly purified. And increasing the dose, doubling the dose of gonadotropin is not recommended because there is no evidence of benefit. Although the multiple pregnancy rate and the ovarian hyperstimulation syndrome will be increased. So the conclusion, gonadotropin is the most effective ovarian stimulation drug. Lastly, this is the last slide in the first part of my talk today about luteal phase support. Are we in need for luteal phase support or not? The benefit only is gained when we are using gonadotropin. And gonadotropin with more than one follicle, the luteal phase support is indicated. While if we are inducing or sober ovulating by clomiphene citrate, there is no benefit. What we will give, we can give the vaginal progesterone or dydrogesterone, the oral dydrogesterone. So this is the first part of my talk.
Very nice, sir.
Thank you very much. We will shift to the second part of my talk.
Yes, sir.
What I will do.
Friends, if you have any questions or any queries, please write down in the chat box or in the question answer box. I will take after just this second session over.
Yes, the second session about the controlled ovarian stimulation. So we differentiated between 3 types of ovarian stimulation: induction of ovulation, sober ovulation, and controlled ovarian stimulation. What stimulation? Again, we will go to the International Society of Mild Approaches in Assisted Reproduction and classify it into natural cycle, modified natural cycle, mild controlled ovarian stimulation, conventional controlled ovarian stimulation, and we will add the new protocols. So, natural cycle, modified natural cycle, mild, conventional, and the new protocol. And our objective in every one is quite different. In natural cycle, we want to get only single oocyte, and no medication is used. While in modified natural cycle, again, we want to get only one oocyte, and only we will use the HCG. In mild ovarian stimulation or controlled ovarian stimulation, our objective to get 2 to 7 oocyte, and we will use a low dose of HMG or FSH. And in conventional, our objective to get more than 8 oocyte, we should use the agonist or the antagonist protocol. And for the new protocol, there are a lot of new protocols, but we will concentrate on 3 new protocols. Let us start one by one. And the conventional, we have the agonist and the antagonist. The mild, we can use gonadotropin, clomiphene with gonadotropin, letrozole, and the new, there are many, but we will only discuss 3. Let us start by the gonadotropin to be used. There is no difference between the recombinant FSH and other gonadotropin. The HMG, the highly purified FSH, or the purified FSH. You can use what you want, and there is no difference at all in the outcome, even in the ovarian hyperstimulation syndrome or in the incidence of pregnancy. Let us start by the conventional protocol. And for the conventional protocol, we have the agonist protocol and the antagonist protocol. And the agonist protocol, we have 3 types. The ultra short, which is rarely used nowadays, and it is based on the initial stimulatory effect of the agonist on the gonadotropin secretion, which lasts for 24 to 48 hours. And in this condition, the agonist is given from day 1 to day 3 and stop. And to continue to start the gonadotropin from the 3rd day of the cycle. This is an example of the ultra short. We started here by the agonist for only 3 days, and then the gonadotropin till the day of triggering with HCG. The second is called short protocol or short agonist protocol or flare-up protocol. The agonist from the 1st day of the cycle until the day of ovulation, until the day of triggering, we will continue. But we will give the gonadotropin from the 3rd day of the cycle. This is an example. We started here with the agonist, 0.1 milligram per day. And from the 3rd day, we started the FSH, and we continue both together till the day of the trigger. That's to say, when we have at least 3 follicles with diameter 18 millimeter, we will trigger. The 3rd, which is the long agonist protocol. The agonist, we have 2 protocols, the follicular one and the mid-luteal one. The follicular one is rarely used nowadays, but we are using the mid-luteal long agonist protocol. That's to say, in the day 19 or 21, we will start the agonist, until sufficient inhibition of the gonadotropin release, the patient will get the cycle, and after that we should be sure that there is a down regulation or there is a desensitization. When this, we will start the gonadotropin. And this example for this, for the long agonist protocol, luteal phase, we started here in the day 20 with the agonist, and the patient gets the cycle. We will determine the E2. It should be less than 50 picogram per mil. And in this condition, we will start the FSH and continue till the day of triggering. As we mentioned, we should be sure that the patient is down regulated or there is a criteria of suppression. We are depending on on the E2, which should be less than 50 picogram per mil, but also the progesterone should be less than 1 nanogram per mil, and the LH less than 5 international unit. Some are not dependent on the hormones at all and depending only on the ultrasound. When the criteria, the ultrasonographic criteria of suppression are no ovarian cyst, endometrial thickness less than 6 millimeter, and in this condition, in 95% there is a suppression. What are the advantages of the long protocol versus the short and ultra short? Let us go to the Cochrane systematic review in 2000 and found that the long agonist protocol is superior in terms of follicular development, number of embryos suitable for transfer, but we are in need for more units of gonadotropin in this condition. And let us, and as I mentioned, nobody is using now the follicular protocol, but they are using the mid-luteal because it is optimal for gonadotropin suppression. Let us go to the recent guidelines of the H3, and I have the honor to be one of the international reviewer of these guidelines, controlled ovarian stimulation, and to see according to the H3 guidelines, the long agonist protocol is recommended than the short or the ultra short agonist protocol. The second protocol, so the first one of the agonist protocol was the we have 3 types. We have the ultra short, we have the short, and we have the long. The second type is the antagonist protocol. We should keep in mind when we are giving the antagonist, there is inhibition, immediate inhibition of LH and FSH without flare up, not like the agonist. The antagonist, the effect of the antagonist is quite different from the agonist. And that's why we have 2 protocols, but what we are using is the small daily or the lobic protocol. That's to say we will give HMG or FSH from day 2 or day 3 of the cycle, and then to give the antagonist 0.25 milligram daily subcutaneously. And we have either the fixed protocol or the flexible protocol. The fixed protocol, if we started the antagonist on the day 6, and the flexible protocol, if we started the antagonist on day, when the leading follicle is 14 millimeter. And this is an example of the antagonist protocol. On day 2, we started the gonadotropin, and on day 6, we started the antagonist, or we started when the leading follicle is 14 millimeter and to continue till the day of triggering. And in this condition, we can trigger either by HCG or with the agonist, because the agonist will be associated with flare up and the increase of the steroids. Let us compare between agonist and antagonist. Antagonist protocol, short, simple, significant decrease in severe ovarian hyperstimulation syndrome, and decrease also in the amount of gonadotropin. And according to the recent studies, there is no evidence of difference in the live birth rate. Let us go to the ISHRI guidelines. In 2019, the antagonist protocol is recommended over the agonist protocol. Why? Because of its efficacy, because of its safety. This is in general IVF population. How to trigger? We have 4 methods of triggering. We can trigger by HCG, and the usual dose is 10,000 international unit, administered 34 to 36 before the time of the oocyte retrieval. Let us go to the recent guidelines of the ISHRI, recommending to reduce the dose, not to give 10,000, but to give 5,000 international units of HCG for oocyte maturation, because there is no difference between both, between 10,000 and 5,000, but with 5,000, the incidence of ovarian hyperstimulation syndrome is less. When to give? We will see what we are doing and what's our practice. We are giving the HCG, triggering with HCG, when we have at least 3 follicles with diameter more than 18 millimeter. And the E2, 150 picogram per ml per every follicle more than 15 millimeter, and the endometrial thickness more than 8 millimeter or triple line. Let us see what is the recent guidelines of the ISHRI in 2019. The decision on timing of trigger is multifactorial. Didn't depend only on the size of the follicle. It is one of the parameters, but also the hormonal data, the duration of stimulation, the financial cost, the experience of the previous cycles. All of this should be put in mind. And most often the final oocyte maturation is triggered at a size of several of the leading follicles between 16 and 22. So we can trigger at 16 millimeter up to 22 millimeter. The ISHRI guideline doesn't recommend to base timing of final oocyte maturation triggering on E2 level. Not only this, but also the ISHRI guideline doesn't recommend to base the timing of final oocyte maturation on the estradiol bare follicle ratio, as we mentioned in the previous slide. There is no evidence of difference between recombinant HCG and or recombinant LH or the urinary HCG. This is the Cochrane systematic review on 2016 as regard the live birth, the ongoing pregnancy rate, or the ovarian hyperstimulation syndrome. But let us see what is the new guidelines of the ISHRI in 2019. The use of recombinant HCG and the urinary HCG is equally recommended for final oocyte maturation. And what is new? It is not recommended to administer the recombinant LH to trigger the final oocyte maturation. The second method of triggering is to use the antagonist. Is to use the agonist in the antagonist cycle. So we can trigger with agonist in antagonist cycles only. And according to the ISHRI guidelines, this is very important. Use of agonists for final maturation with the conventional luteal support and the fresh transfer is not recommended. Is not recommended. When you are triggering with the agonist, the pregnancy rate is lower. The best is HCG. So the ISHRI not recommending in the to trigger with the agonist. only we are obliged to trigger with agonist if there is a high risk of ovarian hyperstimulation syndrome. And the co-administration of agonist and low dose of HCG simultaneously, sorry, this is the third type, which is the dowel trigger. So we have HCG trigger, agonist trigger, dowel trigger. Dowel trigger, that's to say to administer the agonist and the low dose of HCG simultaneously. A bolus of agonist administered concomitantly with a bolus of HCG, depending on the body mass index and the risk, and the author claimed that the pregnancy rate increased and without ovarian hyperstimulation syndrome. The fourth type is the double trigger. So there is a difference between dowel and the double. In double trigger, we will not administer the HCG and the agonist in the same time, but it is separated by 6 hours. So the agonist and the HCG 40 and 34 hours prior to oocyte retrieval. The indications of this is the treatment of empty follicle syndrome, patient with a history of immature oocyte retrieval or low bore oocyte yield. It is indicated in high responders, the agonist with a reduced dose of HCG, and indicated also in normal responder. But let us go and see what is the recommendation of the ISHRI. The ISHRI not recommending this. The addition of agonist to HCG as a dowel trigger for final oocyte maturation is probably not recommended for predicted normal responder. They are not recommending it if we have a normal responder, right? How to monitor the cycle? We will address here the new recommendations of ISHRI guidelines in 2019. And it's quite different from our practice. Number one, addition of E2 measurement to ultrasound is not recommended. Number two, the E2, the progesterone, the LH measurement of no value and not recommended. The routine monitoring of endometrial thickness is not recommended. And we mentioned this in the recent systematic review in the ovarian stimulation in IUI. Also, the monitoring of the endometrial thickness in controlled ovarian stimulation is not recommended according to the ISHRI, the recent ISHRI guidelines. But what is recommended? One single measurement of the endometrium during the ultrasound assessment on the day of triggering or oocyte retrieval, only to counsel the patient on the potential lower pregnancy chance. When we are obliged to do cycle cancellation in the conventional protocol, and by cycle cancellation we mean to discontinue ovarian stimulation prematurely without oocyte retrieval. And the incidence of cycle cancellation is increased with increasing age. And the indication of this, if we are in the day 10 of stimulation, and only we have less than 3 follicles, mature follicles, what we will do, we will continue endless. And second, if there is a basal LH is elevated, premature LH surge, that's to say it is more than 10 international units. Or if there is elevated serum progesterone and there is a controversy about the cutoff levels of this, and it is correlated with the number of follicles or not, and some taking the 1.5 nanogram as a cutoff level. And lastly, which is very important, if there is a high risk of ovarian hyperstimulation syndrome, again, we will go to the ISHRI guidelines. about the cycle cancellation. A poor response to ovarian stimulation alone is not a reason for cycle cancellation. And the physician should counsel the patient regarding the pregnancy prospect and decide whether to continue or not. But if the agonist cycle with ovarian response more than 18 follicles, there is an increased risk of ovarian hyperstimulation syndrome. And in this condition, preventive measures are recommended, which may include cycle cancellation. What's about the individualization of the controlled ovarian stimulation? As we know, what's meant by individualization? Selection of the protocol and selection of the starting dose of gonadotropin. We have conventional COS or conventional controlled ovarian stimulation in which if it is a repeated cycle and the outcome of the previous cycle was good, that's to say we should use the same protocol. And the individualization, it is the correct prediction of the ovarian response depending on the ovarian reserve test, because it is the most sensitive for the ovarian response. Only now we have 3 ovarian reserve tests: the total interfollicular count, the antimolar hormone, and the basal FSH. And this is the cutoff of levels according to the NICE. And according to this table, to select the starting dose of FSH and to select the protocol. Just to say, if the interfollicular count is more than 7 and the AMH less than 1, in this to start by 5 ampoules of FSH. It is a case of poor responder. I know the new recommendation now is not to increase it than 300 international units. And for the protocols, we have a lot of protocols for treatment of low responders, but nothing can be recommended. The high responders, if the interfollicular is more than 14 and the MH is more than 3.5, only 150 international units. And in this condition, it is recommended to use the antagonist protocol. And for the average or the normal responders, that's to say from 7 to 14 interfollicular count, we can use either the agonist or the antagonist protocol. So this is regarding the conventional stimulation protocol, the agonist protocols and the antagonist protocol. What is about the mild stimulation protocols? Mild stimulation protocol is defined if we are administering FSH or HMG at a lower dose. That's to say, not increase 150 for a shorter duration, or we depend on the oral compounds, clomiphene citrate or the letrozole, used alone or in combination with gonadotropin. And the antagonist for pituitary suppression and for prevention of premature luteinization. And as we mentioned, our objective to get only from 2 to 8 oocyte. Let us see the first protocol, low dose gonadotropin, as we mentioned, for a short time, and from day 6 of the stimulation to start the antagonist. And this is an example of this. We started the FSH, and then we added the the agonist from the 5th day of the stimulation cycle. Or also a mild ovarian stimulation is clomiphene citrate in conjunction with gonadotropin. As we know, clomiphene citrate is an estrogen receptor modulator, competitive inhibitor of E2, and it has anti-estrogenic effect. maybe it is the main drawback, but it may cause suppression of the premature LH surge while maintaining a positive influence on the follicular development. It is more effective compared to administering HMG alone. And this is an example of this combination to give 100 milligram of clomiphene citrate for 5 days, followed by the gonadotropin 150 international units per day, and to give the antagonist. We can use letrozole instead of gonadotropin, and it's mentioned that the letrozole is superior to clomiphene citrate because it maintains a good endometrial thickness, and it doesn't have a negative feedback mechanism of the hypothalamic. There is a monofollicular growth and decrease the multiple pregnancy, and that's why it is better ovulation and the pregnancy rate than the clomiphene citrate in patients with polycystic ovary syndrome. What are the advantages and disadvantages of the mild ovarian stimulation protocol? The advantages: we are minimizing the treatment burden, and we are reducing the risk of complication. We are using a lower dose of gonadotropin, so the cost is less. And some mentioned that there is a possible association between the mild dose of gonadotropin and the quality of the embryo. And there is a lower per cycle dropout rates, but the disadvantages: the cycle cancellation rate is increased, and we require multiple stimulated cycles to achieve pregnancy. Few embryos are available for cryopreservation, and there is increased cumulative cost associated with multiple fresh cycles. What is about the natural cycle? Just to have idea about the recommendation of the HG guidelines in 2019, there is no evidence to justify the use of natural cycle or modified natural cycle for ovarian stimulation in predicted high responder. The second recommendation, also not recommending to use the natural cycle over the conventional ovarian stimulation in poor responder. So it is not suitable or not recommended for the high responders, and also not recommended for the poor responder. Lastly, what is the new protocols? So we have conventional protocols, mild stimulation protocols, and the new protocols. The first new protocol is the progestogen, to use progestogen. We will not use agonist. We will not use antagonist. We will use progestogen to block the LH surge during controlled ovarian stimulation, especially in polycystic ovary syndrome. We can use the medroxyprogesterone acetate 10 milligram or utrogestan 10 milligram twice daily. We will start simultaneously from day 3 with HMG. Then trigger, and we should freeze all. We cannot do a fresh embryo transfer cycle in this protocol. There is a literature review and found that the progestogen is effective in preventing the premature LH surge, and it can be used in general population and also in fertility preservation not related to oncology. But the main limitation, it requires total freezing and delayed transfer. Let us see what is the recent recommendation of the ISHLE. The use of progestogen for LH peak suppression is probably not recommended. They are not recommending the use of progestogen to prevent the LH surge. And if applied, progestogen can only be used in the context of non-transfer cycles. The second protocol is the random starting ovarian stimulation. That's to say, we can start the ovarian stimulation at any day of the cycle. This depending on the new theory that we have 3 or more waves of follicular growth. And the anterior follicles in the luteal phase had a similar developmental potential. It can be used as emergency fertility preservation before chemotherapy to get a rapid, it is a rapid protocol for controlled ovarian stimulation. And the controlled ovarian stimulation can be started on any day of the menstrual cycle according to Queen et al. In 2016. And he found there is no difference if we started in the early follicular phase, in the late follicular phase, or in the luteal phase. The number of mature oocyte retrieved is the same, and the clinical pregnancy rate is the same, and implantation rate is the same. But let us see to the evidence, to the guidelines of the H3 in 2019. Random start ovarian stimulation is not recommended for general IVF population. Late luteal phase start is not recommended for poor responders. Early luteal phase start is not recommended for normal and poor responders. Luteal phase stimulation could be used in non-transfer cycle. Lastly, and the last new protocol is the double or the dual ovarian stimulation. It is recommended in poor responders and started by the Shanghai protocol. And we have many modifications of Shanghai protocol. There is a 2 subsequent controlled ovarian stimulation courses in the follicular and the luteal phase. Retrieving more oocyte in controlled ovarian stimulation 2, which is in the luteal phase. And this is an example of the Shanghai protocol. But the Ziegler used 2 antagonist protocol. The controlled ovarian stimulation 1 started on day 6 of the post-oral contraceptives, and second controlled ovarian stimulation started after the first oocyte retrieval, 3 days after the retrieval. The triggering in both was with the agonist in the controlled ovarian stimulation 1 and 2. And he got twice as many oocyte per day. Let us go to the H3 guidelines in 2019. Double stimulation in poor responder should fertility preservation cycles. That's all. Thank you very much.
Thank you. Thank you so much, sir, for such a elaborative lecture. Thank you so much. Thank you. Thank you, sir.
Thank you.
Yeah. Sir, there are some questions. With your permission, can I take that questions?
Sure.
Yeah. Sir, we are getting a lot of appreciations. The program has gone live on Facebook and YouTube also. Sir, there is one question by Dr. Nishant. He is writing a very nice session. What is the role of N-acetylcysteine along with clomiphene citrate in ovulation induction?
Yes. N-acetylcysteine have many actions, and it is an oxidant, and also it was, and we published a paper published in the Fertility Sterility about the use of N-acetylcysteine with clomiphene citrate. But the evidence is not so strong regarding it, and we found that there are more superior adjuvant to be used with clomiphene citrate. We have the dexamethasone, and also we published a paper in the Human Reproduction about the use of dexamethasone as an adjuvant with clomiphene citrate, and according to the guidelines, when to use the metformin with clomiphene citrate. If there is insulin resistance, we should add the metformin.
Yes, sir. Thank you. Thank you so much, sir. So there is one more question by Dr. Surya Kumari. She is writing doses and drugs and what days we have to administer in antagonist protocol.
The antagonist protocol about the dose.
Yeah.
The antagonist protocol, we should start, it is 0.25 subcutaneously, either started in the 6th day of the stimulation cycle. This is a fixed protocol, or to start when we have a leading follicle 14 millimeter. The dose is the same for the antagonist, 0.25. Either we are using orgalotron or we are using any other antagonist.
Okay, sir. Thank you. Sir, there is one more query. Sir, in the patients with low AMH, sir, what's your protocol in that patient?
Yes, the low responders and the low, it is a challenge, and there is no evidence to support one protocol over the other, but all what we will do in this condition to give all are experimental. There is no strong evidence for it. All the adjuvant of no effect, all the adjuvant.
Yeah.
But if you want to give, you should give the cheap one, right? Because the growth hormone is very expensive.
Yeah, I want to know that opinion only, your opinion for the growth hormone.
Yes, and there is no evidence supporting it. But if we classify the new Poseidon classification to classify the poor responders to 4 groups, I think this is a good idea to select the protocol. And we have the group 1 and the group 2, which is hypo responder. And in this condition, we can increase the dose. While in group 3 and 4, there is no value at all of increasing the dose of gonadotropin.
Yes, sir. Okay. Thank you so much. So there is one more doctor is joined. Name is not displaying here. I think she is Dr. Faiza. In poor responder, can we use plasma injection?
Plasma injection. Yes. I reviewed this issue about the use of, we have 2 types of the plasma, the platelet-rich plasma.
Yeah, PRP therapy.
The platelet-rich plasma can be used intrauterine. And we have indications for this: repeated implantation failure.
Yeah.
And thin endometrium.
Yeah.
And this is, there is a good evidence or a growing evidence for this. And it is not invasive. But in the poor ovarian reserve, the use of intra-ovarian platelet-rich plasma, there is no evidence still now. And it is invasive, and all the studies are not controlled studies. And I think there is one study from India, and it is presented in the last issue, and he found that the intra-ovarian platelet-rich plasma of no value. But again, it was not a randomized controlled study. It was an observational study. I think the number of patients was 30 patients. It is an Indian study. I cannot remember the name of the author.
Okay, sir. So thank you so much, sir. I think that there are no more questions. So thank you so much, sir, for enlightening all of us. I hope
Thank you very much, and I am sorry for this delay. It was out of my order, and but I would like to thank you. And I would like to meet you again, inshallah. Extend my regards of all the India, and I have a lot of friends there, right? And the best wishes for you and for the Indian doctors.
Thank you so much, sir.
Thank you very much. Bye-bye.
Yeah, bye.
Bye-bye.
Thank you, InnovaCare Life Sciences, for supporting this program. And thank you, friends, all of the friends who have joined this program. Friends, join us tomorrow at 9:30 p.m. We are having two very interesting topics tomorrow. What to give for the ovulation trigger, pros and cons. And another topic is intermittent fasting. So friends, join us tomorrow again at 9:30 p.m. Tomorrow we are having the 49th episode of the Pundit Show. Bye-bye, friends. Stay safe, stay
Bye-bye.
healthy.
Bye.
Bye. Bye.